Good evening, respected IMA leaders and senior members of our team. It's my pleasure. I'm so happy to introduce Dr. Amal, my friend. Dr. Amal Jose did his MBBS from Calicut Medical College. He's the 50th batch. He's the golden batch of Calicut Medical College. And he did DNB in anesthesia from Lakeshore Hospital in Cochin. And after that, he did a fellowship diploma in critical care medicine from Baby Memorial Hospital in Calicut. And following which, he worked in Mitra Hospital, Calicut, as well as Avitis Hospital, Palakkad. And currently, he is working as one of the chief intensivist in Sreechand Speciality Hospital. Today he'll be speaking on the flip side of bee sting. I'm sure all of us would have encountered a case of bee sting in our clinical practice. I think, but today he's going to show us a different spectrum of bee sting, which we are not commonly encountered. Thank you. With which, let me invite Dr. Amal for the speech.
Good evening, all. It's a privilege for me to present a case to discuss something with such senior staff, and I'm so happy about this occasion, and I thank IMA for the same. I'm Dr. Amal Jose. I work as intensivist in Sreechand Hospital. So most of us would have actually, as Dr. Prasad told, we would have seen and treated cases of bee stings multiple times. But many a times bee sting corresponds to anaphylaxis. But I would like to talk about the flip side of bee sting, which we'll come into. I'll first discuss a case scenario very briefly. The patient, his name was Rajan, and he was a 61-year-old male. And while he was working in his field, cultivated land at Kannur, it's near Iriti side, he got sustained an attack from a swarm of bees, more than like hundreds of them, at around 5:20 p.m. on 7th of February this year. And he was rescued by the fellow workers there, and they took almost 15 to 20 minutes to rescue this person. And initially, he was taken to a local hospital from where he was given first aid, and later he was referred to Sreechand Hospital for further care. And by around 7 p.m. same day, he reached Sreechand Hospital. And on detailed evaluation, at 61 years, he had only one history of hypertension as comorbidity, nothing else. And almost 150 stingers were removed from his body, more from his face and neck area and the limbs. 150 stingers. My colleagues in the emergency department told me that they removed almost 30 bees from the nose, inside the nose, nasal cavity. And after initial resuscitation, he was shifted to our unit, critical care department. Once he reached the MDSU, his A, B, C, D were like this, like airway was partially maintained. He was having maintaining saturation on room air 99% and not very tachypneic. But since he was having severe pain to the bee stings, his heart rate and BP were on the higher side. But at that time, he didn't have any features of shock. His GCS was E3V4M5 then. Maybe it was due to some sedative analgesics which he would have got from the first hospital he reached. And the temperature then was 98.6 normal, and he had multiple bee stings all over the body, more in the face, with facial edema setting in then itself. And we did the screening echo. It was fair LV function, nothing significant was there, all normal. And the first 2 days, I'm not going so detailed with how the patient was there, but I'll go directly into the point. The first few investigations in the first 2 days were like this. The creatinine on the first day was 1.4 and the next day it raised to 1.52. CPK, the initial day was 1,131 and the next day it became 4,000. SGOT, SCBT showed mild elevations and the first day his tropi was 0.94, which serially elevated to 1.73 and 2.74 on the next day. So on the second day, that is 8th of February, patient was actually restless. He was complaining of severe pain. The facial edema was increasing. He reached by around 7 o'clock on the previous day, and next day morning, I'm telling. And then by then he had he was having hypotension, probably due to the anaphylactic shock, and also he was having metabolic acidosis due to the AK setting in. The respiratory rate was on the higher side. And considering the possibility of the potential airway edema and hemodynamic instability and the worsening of acidosis due to this acute kidney injury, he was intubated electively. We didn't wait for a crash intubation. We electively intubated him then, and supportive treatment was started. So consider since his CPK was rising in that trend, like 1,000 to 4,000 in a few hours, we started him on IV fluids like 125 to 150 ml per hour fluids were given. And because since and his LV was also good then. Antibiotics were started, steroids, antihistamines, analgesics and sedation, and other supportive measures, including mechanical ventilation, was continued. The next 3 days, that is from 9th to 11th of February, over the next 3 days, patient slowly improved. He was initiated on antiplatelets and anticoagulation, heparin, in view of acute coronary syndrome because he had ECG changes and serial tropi elevation. And the cardiologist was consulted, and after consultation and discussion with him, we started him on antiplatelets and heparin. Fortunately, there was no need for hemodialysis to be initiated for him since the urine output improved over the next 3 days and creatinine normalized in 2 to 3 days. And he didn't have any other compelling indications for dialysis like hyperkalemia. And on the third day, the CPK rose to 9,000, and then the next day it fell to 5,000. He also had thrombocytopenia, but not very significant, but around 50,000 to 1 lakh in between like that. So the major concerns which we faced while treating him, it was not anaphylaxis for us. It was more, these were the major concerns we had: rhabdomyolysis, worsening acute kidney injury, acute coronary syndrome, liver dysfunction, and hemodynamic instability. These were the major concerns which we had. So we'll discuss something. I will just stop the case discussion for time being, and we'll have a little discussion about the bees and how they are classified and how something more about the bees. So these bees and wasps, they are classified under this phylum Arthropoda, but order of Hymenoptera, we call them Hymenopterae. And it's there are 3 families: Epidae, Vespidae, and Formicidae. We have bees and wasps commonly here. The stinging Hymenoptera, it can be classified like winged Hymenoptera and wingless Hymenoptera. The winged ones are the honeybees, bumblebees, jackets, hornets, and wasps. So this year, we all will be aware that we had a higher temperatures. So like Iriti and all these regions were having temperatures like 39 degree and all. And bee stings are more common in such hotter climates. The stings usually are in response to provocation, but need not be the same always, because unprovoked attacks are not very rare. And we had a series of 7 to 8 patients coming in over just 3 weeks. In 3 weeks time, we got some 7, 8 patients. The surprising fact is that none of them were provoked by stings. It's all unprovoked stings. And this all happened in like almost 30 kilometer perimeter of Iriti region. Could be related to the hotter climates there. And they were all referred to Kannur for further care. when the patient presents with numerous stings, either it be due to wasps or there is a higher chance of mortality. As the number goes up, there is a chance of higher mortality because the mortality or the organ injury happening in these stings, actually it is due to two mechanisms. One is a direct toxin effect causing organ injury. The other one is a toxin induced allergic response, which is IG mediated. So I'll discuss few topics on that. So our patient, he had rising CPK, and since the first day, from the first day itself, he was complaining of pain. In such a scenario, when the patient complains of pain, excessive pain, we will usually attribute it to the stings which he had. That definitely causes pain. But another factor which we should be considering is the rhabdomyolysis, because the rhabdomyolysis is a complication of such stings where the patient will present with pain. The rhabdomyolysis is a syndrome characterized by muscle necrosis and release of these potentially toxic intracellular muscle constituents like creatine kinase, myoglobin, LDH, aldolase, and various electrolytes, including potassium, phosphorus, etc. So these get released into the circulation and cause the damage. The severity of rhabdomyolysis, it varies. It can be simple elevation of the CPK without any symptoms, and it can vary, and it can even cause life-threatening disease associated with extreme enzyme elevations, electrolyte imbalances, and acute kidney injury, even causing death. The clinical triad of rhabdomyolysis consists of the pain, that is a muscle aches, weakness, and dark urine. So this triad, it's a classic triad, but we don't usually see it in all cases. The classic triad is seen only in less than 10% cases, but most patients will complain of pain and weakness. Pain is actually present in 20 to 80% of patients, and most of the complaints will be in the proximal muscle groups like thighs, shoulders, etc. Same is the distribution of weakness also, and 12 to 70% of the patients will complain of weakness also. The last one, dark urine, it's actually present in less cases, less than 10% cases. And to differentiate between myoglobinuria and hematuria, we can do an urine analysis. Myoglobin being a monomer, the structure is being a monomer, and it is not significantly protein bound. Hence, the myoglobin appears in urine much easier, means much at a very less plasma concentration compared to hemoglobin. Hemoglobin is a tetramer which is protein bound. So the chances of it appearing in urine is at a higher concentration only. Myoglobin appears in urine when the plasma concentration is above 1.5 milligram per deciliter. But the visible changes happen only at a higher concentration, like more than 100 mg per deciliter. So coming to pathophysiology of rhabdomyolysis, irrespective of whatever inciting agents causing rhabdomyolysis, it all come into a final common step, which leads to rhabdomyolysis. And the steps are direct myocyte injury and failure of the energy supply within the muscle cells. This is a flow chart showing the mechanism, but I'll just simplify it like the various causes of rhabdomyolysis are shown in the box. And these causes rupture of the plasma membrane of muscle and depletion of ATP, further leading to increased concentration of sodium and calcium inside the muscle cell. So the increased sodium concentration and increased calcium concentration in the muscle cell leads to further damage of muscle membrane, cell membrane, that is the sarcolemma, and also generation of calcium-dependent phospholipases, proteases, etc., which further aggravates the injury. So that is the mechanism of rhabdomyolysis, and the end result is it causes an inflammatory, self-sustaining myolytic cascade, which causes the necrosis of muscle fibers, and the necrosis of these muscle fibers potentially leads to the release of such potential toxic contents, which I have already explained, to the bloodstream. Complications Complications include acute kidney injury, compartment syndrome, hypovolemia, electrolyte imbalances like hyperkalemia, hyperphosphatemia, hypocalcemia, DIC, etc. So these are all complications of rhabdo. And the treatment is actually resuscitation of the patient, assessment and stabilization of the ABC, airway, breathing and circulation, and identifying the cause and the correction of the same, fluid resuscitation, permitting if it's the patient is having a good LV function, the patient can be given according to the scenario, we can say that our patient had received 125 to 150 ml per hour for the whole day. And measures to prevent acute kidney injury like urinary alkalization, loop diuretics, etc. And correction of metabolic abnormalities. These are the cornerstones to treatment of rhabdomyolysis. And then next entity is acute kidney injury in a patient with bee sting. Since the kidney is a highly vascularized organ, it is very vulnerable to the toxins of Hymenoptera stings. And the mechanism are varying, different. It can be caused due to the acute tubular necrosis, rhabdomyolysis, direct venom toxicity causing interstitial nephritis, and also the shock which patient ends up will lead to hyperperfusion and pre-renal decay. All these are mechanisms which contribute to the acute kidney injury in such patients. Usually the renal biopsy in patients who succumb to illness, actually it reveals acute tubular necrosis and occasionally acute interstitial nephritis. The mortality of a patient who presents with bee sting with AK is actually higher, like more than 25% mortality is there when a patient presents with a bee sting plus AK. Hymenoptera toxin, I'll just mention the components of the toxin: melittin, phospholipase A2, hyaluronidase, all these things are there. Melittin actually causes disruption of the cell membrane and direct toxic effect on the renal tubules. Phospholipase A2 is a pro-inflammatory molecule, and hyaluronidase actually causes breaking down of the connective tissue, contributing to the spread of venom. Other toxins may cause rhabdomyolysis, myocardial necrosis, etc. And the outcome of a patient with acute kidney injury in a bee sting, actually it depends on how fast the AK resolves. And the major treatment strategies: correction of hypovolemia, attending the renal ischemia, clearance of toxins, and alleviating the direct consequences of toxins. The treatment options are optimal hydration, alkalization of urine, and if warranted, renal replacement therapy. Alkaline diuresis actually reduces the dissociation and precipitation of myoglobin into its nephrotoxic metabolite. There is a metabolite called ferrihemate, which is potentially nephrotoxic. So alkaline diuresis can help in reducing the nephrotoxicity of myoglobinuria. And early RRT is initiated in most cases. And depending on the hemodynamic stability of the patient, we can start either hemodialysis, SLED, or CRRT. And the last one which I want to discuss is the Cooney syndrome. Cooney syndrome, it is described as or defined as a myocardial ischemia or infarction that occurs in the setting of anaphylaxis. It's the mechanism behind it is a venom-induced allergic reaction causing vasoconstriction, severe coronary vasoconstriction. It was first described by Cooney in 1991, hence called Cooney syndrome. Activation of these cytokines, leukotrienes, etc., is the reason behind the vasoconstriction. And there are three types. We can briefly classify it as like type 1 is in a patient, normal patient with no comorbidities. Type 2 is in a patient with pre-existing atherosclerotic disease. And type 3 is the formation of thrombus inside a stent due to the hypersensitivity reaction. Our patient, he was actually belonging to the type 2 category since he was elderly and having hypertension. We classified him under the type 2 category. And the management is type 1 just needs hydrocortisone and chlorpheniramine. It doesn't require any antiplatelets or anticoagulation. Type 2 conventional antiplatelets and anticoagulation are used along with antihistamines and steroids. And type 3, it's the patient is already on antiplatelets and management includes master stabilizer, steroids, and antihistamines. So back to the case. So I just discussed few complications which our patient had, and most of the patients which came in that series, like six to 8 or 9 patients came, most of them had most of these complications. Especially, we didn't had to manage so much of an anaphylaxis in any of them. The potential cause of morbidity and even mortality of one patient was these rhabdomyolysis, acute kidney injury, etc. So this particular patient actually had these complications, all of these complications, later improved with supportive treatment and hemodialysis was not warranted. And after 4 days of treatment in the MD ICU, he was shifted to room. On 17th of February, after 10 days of total treatment, patient was conscious, oriented, hemodynamically stable. All the blood tests were back to normal. Patient was clinically fine. Facial edema was there, mild facial edema. Otherwise, he had no other fresh complaints. And on 17th of February, he was discharged home. So I was, when I thought about presenting this topic, I just wanted to um, explain or like discuss the other side of beasting, because everybody will think about anaphylaxis. I didn't want to discuss anything about anaphylaxis because it's a common practice to treat and manage anaphylaxis in a beasting patient. My intention was to discuss the other side. Thank you. Yes, sir. Completely reversible. Completely reversible. Many means many a times this severe metabolic acidosis, hyperkalemia, all the complications of this AK can go into a irreversible damage to the organ systems. And actually, out of the 8 to 9 patients received, we had one patient who died the very next day. Even after we treated all the patients in the same manner, the same protocol was followed. But despite all the treatment given, the second one patient, we lost one patient. Even we had done one episode, one sled also, one dialysis session was also done, but still we couldn't save him. So AK is a independent risk factor for death in such a patient. Scorpion bites can yeah, in here what happens is like when there are more than like 50 bee stings, the chances of rhabdomyolysis and such complications are higher compared to anaphylaxis. When there are fewer stings, the chances of rhabdomyolysis are so small that the concerning thing will be anaphylaxis. But when there are higher number of stings, automatically there is a shift in our concerns. More than anaphylaxis, what worries us will be the side effects which we mentioned, just like mainly rhabdomyolysis and acute kidney injury. If you're taking single organism, means like if you're taking a single honeybee and single wasp, it will be wasp because the amount of venom will be higher. But usually the attack happens when the honeybees attack, it happens in a group. So there's a chance that we can get an attack from like 150 or 200 honeybees, but wasp stings usually present us with lesser number of stings. So, but both can cause death.
No more questions. Vote of thanks by Secretary.
Our sincere thanks to Dr. Amal Jose. Thank you, Dr. Amal Jose. Also, I thank all AMA members. Today's hearing. Thank you.